Tuesday, Wednesday, I don't know what day it is, January 15th, 9 a.m. House Healthcare. Welcome. We had a couple housekeeping things. We do need to elect a clerk. However, because we're short some people early this morning, I'm going to hold off till a little bit later to do that. Additionally, I wanted to mention that yesterday evening, I decided that we're going to finalize our guiding principles tomorrow morning. And so I'd like everyone to be thinking through the evening and be prepared if you have anything that you'd like to input or something you're uncomfortable with. So we're going to do that tomorrow. Today, this morning, we are, we got an overview from JFO yesterday, sort of on just healthcare 101, sort of our system of care in the state of Vermont. And so this morning, thought we'd bring in a lot of the advocates who represent various organizations within our healthcare system. So today, these are sort of health provider advocates. And you'll see a lot of these people in the room all the time. And so important to get to know them. And you're going to start with Mary Kate Molman from Bi-State Primary Care.
Let me just launch my slides.
Maybe the two newbies.
Let's present it. Great. Well, thank you, Madam Chair, members of the committee. For the record, my name is Mary Kate Molman. I am the Director of Vermont Public Policy for Bi-State Primary Care Association. For my presentation today, I'm just going to give an overview of what Bi-State is as a primary care association, review of our members, focus mostly on our federally qualified health center members, look at what they do and their role and their value in Vermont's healthcare system, and then give an update on the status of how they are faring. Little spoiler alert, it's not pretty.
You're going to hear from me.
All right, so what is a primary care association? That's what Bi-State is. PCAs are designated by the federal government to support community health centers. There is a PCA in every state. In the situation for Bi-State, we represent 2 states. So we represent FQHCs and FQHCs in New Hampshire and Vermont. I'm clearly here to talk about the Vermont side. We've been around for almost 40, Bi-State's been in existence for almost 40 years next year. We represent 26 member organizations across our 2 states. In Vermont, that's 11 FQHCs plus Planned Parenthood of Northern New England and the Vermont Free and Referral Clinics. Believe you will hear from my colleague to talk about Planned Parenthood of Northern New England, so I won't focus on them too much, but and I'm also happy to answer questions on the free and referral clinics. So what do we do as a PCA? We provide a lot of technical assistance, training to help with quality, performance, clinical quality. We have a center that does national recruiting for physicians, physician assistants, nurse practitioners, and dentists to try to bring in practitioners to practice in the state of Vermont, as well as New Hampshire. And this is to place not only at FQHCs, but any health organization in the states. We work with our federal and state organizations on strategies and policies to support community-based care, really focusing on the primary and preventive population-based care. We have a team that does a lot of data analytics and data management for our members. And we also have a program that's really working on how to increase access to not just food, but nutritional food, making sure we are getting those, not just calories to people, but food that really helps and support their health and well-being, and a number of which we see a lot in chronic conditions. So that's a quick summary of bi-state. Like I said, I'm going to focus on our federally qualified health centers, FQHCs. These are also organizations designated and established in federal statute, designated by federal statute to support care of our most vulnerable individuals, marginalized populations, in areas that are really experiencing shortages both in providers and services. As safety net providers, we are required by federal law to participate in Medicaid. This means that we can't close our practices to Medicaid enrollees. We must see anyone regardless of ability to pay or their insurance status, meaning we can't turn patients away. We also must establish, or FQHCs must establish, a sliding fee. This can help reduce the out-of-pocket for our patients. Can be cover the full cost of a visit, especially for those with self-pay. It can also help offset any amount due to go towards deductibles. It can also go towards reducing copays. This can be important even for Medicare and beneficiaries, because some patients struggle with their 20% copay for Medicare, and these sliding fees can go towards reducing that burden. They also have to have a governing board with more than 50% patients serving on the board. This really means that there is a strong focus on what the community needs and how to meet those needs. This can manifest in one of our health centers, Notch, has a grocery store. They run a grocery store, and that can be just for the community, making sure there is food access in that community. It can also be, hey, let's walk down and look what kind of food you need to help with your health conditions. Funding. So the FQHCs do get a federal grant to help run as an FQHC. To qualify that and be recognized in FQHC, they must go through a very competitive national application process. Once they receive that recognition, they have to continue to meet strict program and performance and accountability standards. They get site visits, I think once every 2 years, and this is a very thorough review of how they operate as a healthcare organization. It can go through looking at their overall provision of care, their record keeping, down to whether or not everyone's wearing a name tag. So it can be very detailed and a lot of strict standards. In addition to all of our health centers are patient-centered medical homes. So in addition to having to meet all of those standards, to continue their recognition of an FQHC, they must meet an additional approximately 100 additional regulations connected to their status as an FQHC. So they are highly regulated. Payments from Medicare and Medicaid, they get a set payment per visit. Call this an encounter rate. I can get into the really nitty-gritty details. I won't, I'll spare you. But this is really, they get the same rate whether they come in for a fairly straightforward wellness visit, or if they come in and see multiple providers to address multiple conditions and needs. So they get that one set rate regardless of what occurs in that visit. They get the same payment from commercial payers as other primary care. So that's the same. The 330 grant funding and our 340B prescription drug program savings really go towards allowing them to meet community needs. FQHCs are not allowed to use their 330 grants to supplement the cost of care, providing care to Medicare or Medicaid patients. That dollars are meant to meet the needs, the standards that they must need to operate as an FQHC. And it also really goes towards providing care to their patients. That sliding fee scale comes out of the 330 grant and all of the other stuff that they need to do to meet their patient needs.
Can you give a 30-second synopsis of what 340B is?
Yes, this is a program that was established in, again, federal law where covered entities, safety net providers, that it was intended to really help scarce federal dollars stretch a little bit further to provide safety net services for underserved and vulnerable populations. What it allows covered entities to do, and FQHCs would be considered a covered entity, is they are allowed to purchase prescription drugs at a reduced price. And then that prescription is given out, they get reimbursed for that prescription at the regular rate, the same rate that a payer would pay any other pharmacy or provider for that drug. So that delta, that difference between what they pay for that drug and what then they get in reimbursement for that drug is a net savings that they can use for things like providing free dental care, going towards the sliding fee scale, going towards school-based clinics. So that really allows them to really meet community needs.
Okay, thank you.
Okay. All right, so we talk about the integrated care, and this I want to focus on FQHCs. They are community health centers. We often get lumped in with the primary care providers, and they are community health centers that do provide primary care and mental health services, substance use disorder treatment, reproductive health services, vision care, oral health services. They are often the only provider in an area providing dental and accepting new Medicaid patients in their dental practice. They provide school-based services, which can include physical health, medical health, as well as mental health services for our kids. On top of these core services, we have these enabling services. This can be the nutrition, counseling, economic support services, housing support services, transportation. We're required to provide translation services. And then there's a real coordination of care across the community partners. So where do we serve? We have 11 health FQHCs in the state with 96 sites operating across every single county in the state. We serve about 1 in 3 Vermonters. We over a third of Medicaid enrollees go to federally qualified health centers in Vermont. And you can see, I won't list all of these, but we really, it's that outreach to those populations often most in need.
Yep, just want to pause for a second. I think we have 2 questions. 3. Oh, I'm sorry, I didn't. Check my peripheral vision. Topper.
On the last slide, you had housing services. Can you talk a little bit about that?
It's the support around any kind of work they need to do, like connecting them with the housing, whether it's counseling for how to pay your rent. Obviously, we don't use our money for paying rent, but it's that support around how to pay rent, like that. Often it's a mental health conversation around how are you managing all of the different responsibilities to make sure that you are paying your rent or your mortgage or anything else you need to do to make sure you stay housing secure. It might be referrals to a houser. It might even be working with your local Habitat for Humanity. So it's really looking at what are the patient needs and how can we meet those and get those and reduce those barriers.
Leslie, did you have a question?
I did. You can go to your next slide. When you were talking about all 14 counties, do you have a presence in Windham County anymore?
I believe we do. I would have to look.
I think you need to, because
Okay.
I don't believe you do.
Okay. Yes, let me look at that.
Yeah,
Okay.
just to be clear, the Southeast is a bit of a primary care, getting to be a primary care district.
Yes, and I'd be happy to talk to you also about, there's other conversations about how to address that desert.
Great, I
Yeah.
appreciate that.
Did you say there were 11 FQHCs and 96 sites? Can you talk a little bit about the difference between that? Are the 96 sites collaborating organizations or?
So it's the 11 parent organizations that have multiple sites within those organizations. And so the sites can be a dental clinic, a family practice clinic, it can be a school-based clinic. Those would be the different sites under the parent organization. Does that get to your question?
Yeah.
Okay.
So an FQHC isn't just four walls.
Yes. Yeah, just so I'm clear on that, I'm just using, say, Burlington. So Burlington is under, the larger FQHC that has multiple Chittenden County and some islands, I think. But the Burlington Clinic itself, I think that is one. Are you saying that it's multiple because it has dental and?
No, I think it's when I say site, a physical location.
Okay, physical
So it's the different physical locations. So the Essex, the Riverside, the Grand Isle.
Thank you.
Yep. Any other? Okay. All right, so current state. There's often an idea that FQHCs get a lot of extra money. I would dissuade you of that. They do get additional funding, but it's to cover a large variety of services. They operate on a very, very slim margin rate. They have been facing increasing costs, while other funding sources are flat or declining. About the 340B, that has not been adjusted for 10 years. I talk about the 330 grant has not been adjusted in 10 years. The 340B that program is eroding and those savings are declining. Labor costs are going up, the cost of operations is going up. And so we are really struggling. And we are seeing a number of our, pretty much every FQHC in the state is flat or has an operational deficit across.
I'm sorry to interrupt. How's the encounter rate? Is your encounter rate up, down, stable? It hasn't changed?
It has not really changed. There's a lot to unpack on that question. But I would say it has not changed. We are working with DVHA on our Medicaid encounter rate. That work has been ongoing for the last 11 months and we have not seen any update on those. Across our health centers, we're looking at about 8.5 million deficit. We are looking at we have a number of health centers that have less than 20 days cash on hand. We have had sites that have had to consolidate. So North Star in your neck of the woods has had to consolidate a dental, and they have also closed one of our clinics, and that was just to consolidate. And those patients are continuing to be seen by the North Star clinics, but they've had to close the site because they just couldn't afford to keep it open. We have another health center that is playing with the idea that one of the options on the table is declaring bankruptcy. And we have a number of other health centers that are looking at similar, very difficult decisions. And so we as an organization, as Bi-Citizen organization, are very concerned about the fragility of our primary care network and that foundation and whether or not that's going to be able to continue.
Based on that, I noticed on the other slide that you served, I think it was 6,000 veterans.
Mm-hmm.
And they are covered. I'm wondering, spending money on veterans when they have a health insurance plan that they can be part of.
Yeah, and I would say that they would get reimbursed from their health insurance plan.
Okay.
That's
not a drag on you then.
I mean, I don't know the funding, like whether or not that reimbursement covers the full cost of care. That's a separate issue, but we would get reimbursed from those plans.
Are you considered a community provider for the VA?
I don't know. I'd have to double check that. I can get back to you on that.
But you
I
have to
think
serve.
anybody can.
Yeah, you have to agree to be.
Yeah.
Anyways, if you want to move, go on.
Yeah. Oh, that's just the end of my slides. Yeah.
All right.
I'm just leaving you with some doom and gloom.
Thanks very.
And I would say that our members have been working on being creative, but right now where we are, that creativity is only stretching so far.
Okay.
Right, so I'm happy to answer any other questions either now or later.
Thank you for coming in and introducing yourself today.
Thank you.
We're going to hear from Jessica Barquist from Planned Parenthood of Northern New England next.
Hello.
Hey.
For the record, Jessica Barquist, I'm the Vice President of Public Affairs for Planned Parenthood of Northern New England. Happy to be here with you all today. Probably going to continue on with the trend of doom and gloom for you all, but hopefully can provide some good things as well. So Planned Parenthood of Northern New England provides comprehensive reproductive and sexual health care to nearly 16,000 people in Vermont. We have 7 health centers located in Burlington, Williston, St. Johnsbury, Barry, White River Junction, Rutland, and Brattleboro. And we serve the whole state virtually through our telehealth program. So people across the state turn to us for affordable, high-quality care, including wellness exams, birth control, STI testing and treatment, cancer screenings, abortion care, gender-affirming care, as well as a variety of limited primary care services. We see everyone who comes to us regardless of their ability to pay, and 54% of our patients have low income. Last fiscal year, we provided $1.3 million in free and discounted care to our communities in Vermont, which is an increase from the previous fiscal year where we provided $802,000 of free care. So just broadly, sexual and reproductive health care providers play a really unique role in our state's healthcare system. First, we sit on those front lines. We see all patients, regardless of their ability to pay, and are a really integral part of the state's safety net. We provide time-sensitive care, reserving time on our schedule each day for same-day appointments, because much of our care begins with addressing an acute need. A patient's birth control prescription is about to expire, they maybe felt a lump in their breast, they're experiencing painful periods, or they're worried they might have an infection. Patients also turn to Planned Parenthood for primary care services, and we can provide blood pressure checks, anemia testing, screening for cholesterol, diabetes, thyroid. We are often the first and only healthcare provider a patient may see in a year due to a patient being uninsured or having low income. We screen patients for mental health, safety and intimate partner violence, substance use disorders, and other social and mental determinants of health. Because of this unique relationship that we have with our patient populations, patients are often much more likely to disclose these deeply personal health issues to our staff. We have licensed patient support counselors in all of our health centers across the state and can help facilitate getting patients into other mental health treatments or longer-term care that they need. Patients have a deep level of trust in us because of the quality care we provide and the high level of honesty we offer as a sexual and reproductive health care provider. We are in an uncomparable position to screen and educate patients, their families, and our local communities about behavioral health and the importance of both prevention and treatment. And it is that relationship that has really led to our expansion of care to meet those needs of our patients more directly. So the reality is that today, a patient walking through our doors receives far more than a prescription for birth control or a pap smear test. Not only are we a trusted health provider in the state, but we also provide public health services, including free and low-cost sexual education in schools and community locations across the state. We also operate a grant program with the Department of Health that allows us to provide free condoms in our middle and high schools across the state. So we are doing both the healthcare in our clinics, but also that preventative work out in our communities. In our health centers, we accept patients with Medicaid, Medicare, private insurance, and we also accept patients without insurance. Low or no cost care is always available for any eligible patient. We also have very generous donors, and over the years, we've asked them to take on more and more of the percentage of patient care costs. So we provide donor-supported funding for eligible patients to cover the cost of care for abortion services, gender-affirming care, and cancer screening. Our payer mix is roughly 28% government, 50% commercial, and 22% self-pay. And so when we talk about free care, that is separate from the acknowledgement that that 22% self-pay are very unlikely to ever be able to pay for those services. And that is often care that we have to write off as well. So as you're going to hear probably from a lot of us today, we have a significantly broken healthcare system. And that, coupled with endless political attacks at our national level, has left Planned Parenthood of Northern New England with a funding gap of more than $8.6 million over the next 3 years. This gap is driven by a lot of things, including systemic failures in our healthcare industry that undervalues the care that we provide. The pandemic, inflation, increased demand for our free and discounted care, and our insufficient reimbursement rates have all compounded to make this situation worse. And unfortunately, we only expect that gap to grow under the new Trump administration, who is already promising to slash our funding and remove us from programs that serve low-income Vermonters. These concerns about federal attacks on services are shared among our patient base as well. Following the election, Planned Parenthood of Northern New England saw an uptick in appointment requests for long-acting reversible contraceptions, often called LARCs. These methods of birth controls, including the implant and intrauterine device, or IUD, can last anywhere from 3 to 12 years. In the weeks following the election, LARC appointment bookings at PPN&E health centers in Vermont more than doubled, from an average of 51 per week pre-election to 105. We're also seeing a post-election uptick in the number of vasectomy consultation appointments, which is that first step in booking a procedure. Numerous patients who receive gender-affirming care with us have also called and just voiced fears about not being able to access those services in the future. So our patients are afraid. They're afraid that they are not going to be able to get the care that they rely on, and that the provider that they rely on might not be there for them in the future. And so we are doing everything we can to make sure that that doesn't come to pass. We have already seen in our state the impact of closing Planned Parenthood health centers. In 2022, PPN&E was facing a similar financial deficit to what we are now. Ironically, the same year that the legislature overwhelmingly passed the Reproductive Liberty Amendment. And we were forced to close 4 health centers in Bennington, Hyde Park, Middlebury, and St. Albans. And I can tell you that anytime I am in those communities, I hear over and over again how devastating those closes were. And patients are like, when are you coming back? We need you here. So we are doing everything we can to make sure that we can keep our health centers open and continue to provide that care across the state for many years to come. And we are going to need your help in order to be able to do that. So we are pursuing many strategies to address our financial gap. These include renegotiating our contracts with our insurance payers, using new technology to make our patient experience more efficient and allow us to see more patients overall, conducting research into our key services and opportunities to expand, and enacting various cost-saving measures. And we also need the legislature's help to keep our doors open and to keep access to sexual and reproductive health care protected for all of our patients and our providers in this state. And so we are hoping that this year in this committee, we will be able to work together to come up with those creative solutions that will help keep Vermont a safe haven and a model of sexual and reproductive health care.
Yeah, I actually just have one. Oh, go ahead, Topper.
Talked about condoms in the high school. Could you talk a little bit about if you do anything in the elementary schools?
We do not. No, we are only in.
Why you don't?
The grant that we have through the Department of Health is for our older student population.
Really? Thank you.
We do offer age appropriate education services to any school who reaches out for them. But the condom program is specifically for our high schools and some middle schools, depending on ages.
Middle schools.
Mm.
All right, thank you.
Leslie, do you want to go ahead?
That's okay. Do you get budget support now? In our budget, the state budget?
We do not currently receive any state funding.
And do you have an
Other
idea of what you're gonna be asking for? How's that gonna play out?
Yeah, I think the biggest and probably easiest is related to Medicaid reimbursements. Because of the federal family planning program, we get reimbursed from the federal government at a 9-to-1 rate. So a modest investment by the state of 85,000 would net us 805,000
Oh, that's what you're talking about.
overall.
Okay,
Yeah.
so if we put in ours, you'll get a federal.
We'll get
match.
that 9-to-1 federal match and Medicaid and the Medicaid reimbursement rate. So that's something we're exploring. We're working with the treasurer's office to look at a special fund that could be created. I'm sure they will want to come in and talk more about that. There are other solutions, and the reality is that we are probably going to be losing some federal funding. And so in the previous Trump administration, we lost our Title X funding, and the legislature was able to find those funds to backfill that to allow us to continue to provide that free and low cost care to all of our patients. And so that might be a conversation we have to have this year too, but we're in that place of uncertainty where we just don't know for sure what's going to happen and what that timeline is going to look like.
I was struck by one number that you said. You said that 20% of your patient population is uninsured. Now, are you talking about Vermont?
22% of our patients are self-pay.
Self-pay,
Yeah.
which I assume to be, can I infer that you're talking about uninsured? I mean, we had JFO in yesterday, 3% of Vermont's population is uninsured. Why do you think you're seeing such a large segment?
Yeah, sometimes our patients have insurance, but it is such a high deductible that they can't afford that deductible cost, and so they will work with us on a different payment plan. Sometimes maybe they're on their parents' insurance and they don't want that record of the care that they're receiving, or they're concerned about that, and so they opt to do a self-pay instead.
Thank you.
Yeah. And I do have our most recent annual exams as well, which I can leave for you all with some of our statistics.
Thanks for coming in and
Thank you.
thanks for the services that you provide.
Thank you.
So next we have Jessa Barnard from the Vermont Medical Society. I will say that anybody is welcome to sit in this first reserved seat unless one of our staff members comes in, then they would need to vacate it. So.
Room limits anymore?
I'm sorry.
Do we have room limits anymore?
I'm not sure. Do we have something posted outside?
I mean, I don't know, we may have moved up from that.
No, room size or number of people in the room. For a while, we used to have a
Limit.
limit. We have some physicians in the room. Are we all safe?
Call us if we're here, if we're okay. I haven't seen anything outside.
Yeah, maybe they went away.
Maybe they're not.
Maybe they're, no, I'm sorry.
COVID is over.
Yay.
Are any committee members uncomfortable?
No.
With? Okay.
Well, thank you.
Fair enough.
Yeah.
And if I may ask the chair's indulgence to let the folks introduce themselves, since a few folks were here with Vermont Medical Society this morning. So I'm Jessa Barnard. I'm the executive director of the Vermont Medical Society. We, unlike some of the other organizations you'll be hearing from this morning, we don't represent a specific facility type. We are an individual membership association. So our members are physicians, physician assistants, and physicians in training, medical students and residents. And so actually had a legislative breakfast this morning. So some of our members are here in the room. If I could just let them say a quick hello. So you see some faces, sometimes staff like myself will be in the seat, but we often try to have our members here. So I don't know if you just mind just saying a quick, please.
Hi, I'm Erica. I'm Katie Wells. I'm a UVM emergency physician, assistant director of medicine and health equity for our network department. And I'm the director of social medicine for the Larner College of Medicine. Nice to meet you all. Hi, I'm Becca Bell. I'm a pediatric ICU doc at UVM Children's Hospital, and I'm the immediate past president of the Vermont Medical Society.
I'm Charlotte. I'm a fourth year medical student at UVM.
So we are, oh, and Stephanie, sorry, Stephanie, do you want to say a quick hello?
Sure, Stephanie Winters. I'm the deputy director of Vermont Medical Society.
Full house of VMS this morning, and that's not typical, but we were just there, since we had folks here for breakfast this morning, I wanted to let them come listen and say hello to you as well. As I said, so they are our members. We are a all medical professional led board. They make the decisions for the organization. They set our policies, make the decisions about what issues we want to engage in and advocate on. And then there are Stephanie, myself, and Jill Sudoff-Garin, you might see in the building, helping translate what they tell us, what their issues are, what their concerns are into issues here at the legislature. We have 3,100 members this year. And as I said, that's physicians, PAs, physician assistants, and medical students. That's about 2/3 of practicing physicians in the state. Some of them are just individual members who pay individual membership dues. We do have some group memberships with some of the hospitals and larger practices who may say, we want all of our physicians or physicians and PAs to be members, and they can sign them up as a group. But we're representing the individual clinicians, not the organizations. Our current president is a family physician. She's actually at an FQHC, Memorial Health Partners in Stowe. And so I'm sure she will be here talking to you on issues. She's been very engaged on issues around prior authorization, administrative burden, support for primary care, workforce issues. So she might be here speaking to you as well. We try to meet our members' need. Oh,
Yeah, I'm just curious, what does it cost to be a member?
our current full membership dues. Oh boy, I'm glad I have Stephanie here. What are our current full dues? $525 a year.
So that's an individual.
One individual. We have various discounts if you join as a group, if you're a new member, things like that. Our membership dues are on our website if you're curious. But that would be, one individual saying, I just want to join for the year.
I know we covered this, I think, yesterday. How many doctors and PAs do we have in the state? And I'm just looking at 3,100 members.
Yeah, so it's not really, it's actually a little bit tricky math or analysis because we have members so the one number you might hear is how many physicians are licensed by the Board of Medical Practice, for example. And that is actually just over 6,000 now. But that includes folks who may not actually be located in Vermont. They may be practicing via telehealth. They may, so actually the licensed number of physicians has increased fairly significantly in the past couple of years because of telehealth. So you might have all physicians at Dartmouth now have both a Vermont and New Hampshire license. So in the past, they could just be licensed in New Hampshire, see Vermont patients in New Hampshire. But now if they're providing telehealth services into Vermont, they may all also have a Vermont license. So that's kind of a greater number than those practicing in Vermont. Our membership is also a greater number than those actively practicing because we include medical students, retired members. So when we've kind of tried to do the apples to apples, who's actually practicing here, our estimate is that's about 2/3 of those located in Vermont practicing here, if that's helpful. Did that answer the
Yes,
question? Okay.
yeah, thank you.
So we try to meet our members' needs in a variety of ways. We have a weekly newsletter where we try to give a lot of updates on legislative activities, regulatory activities, events coming up. We provide education on implementation of various laws, state and federal. We have and I'll give a little detail about our work in practitioner health. And then actually, I'll start with we are also the administrative home for a number of medical specialty societies. So these are their own separate organizations, their own separate boards. They contract with us to provide either administrative support or administrative and advocacy support. And in fact, one of the reasons I wanted to make sure Stephanie was here, she serves as the executive director of a number of these. So we try to work together. You may see us coming in and testifying not just on behalf of Vermont Medical Society, but also the pediatricians and the family physicians or the psychiatrists or whoever may have kind of an issue happening here at the State House. So we coordinate really closely. We do things like help run their board meetings and help them put on their annual meetings, but then also maybe here doing advocacy on their behalf. And it's a really great sort of two-way communication. We learn the issues that really are important to their specialties, and they can also, benefit from us saying, hey, here's what's going on impacting all of medicine or all of healthcare that you may want to pay attention to. One program I'll mention in the area of practitioner health, we actually there is in statute, a designated, there has to be an organization that supports licensees of the Board of Medical Practice. So that's physicians, MDs, PAs, radiology assistants, anesthesia assistants, who have an impaired ability to practice medicine. That could be because of a mental health condition, substance use disorder, other cognitive issues. And we have been awarded the grant from the Department of Health to run that program. It's actually funded by a surcharge on all licensees when they renew their license with the Board of Medical Practice. A portion of that goes to this grant that then we have been the successful bidder to run. So we have a psychiatrist who's the medical director of that program. We help provide assessments or arrange for the individual to be assessed to figure out what their diagnosis might be and come up with a monitoring plan. So either they can continue to safely practice or return to safe practice when they are in, their condition is under adequate management. So it's really a way to keep as many practitioners as possible safely practicing here in the state. So Nels Kloster is our medical director, and he'd certainly be happy to talk more about that program at any time. So our policy priorities, and I'm going to make this a little smaller. So we are very active in the area of policy, not only here at the legislature, but with other agencies, the Green Mountain Care Board, Department of Health, Board of Medical Practice. Stephanie likes to say, health and all policies. So it's a wide ranging area of issues that our members care about and ask us to be engaged on. So I'll run through some of them. I say priorities, and obviously not all of these can be our top priority, but these are kind of gives you an example of the breadth of issues we're working on. It's not a complete list because there's certainly a lot of bills that come up. Who knows, in other committees, transportation, dealing with seatbelts, safe, data privacy that will be coming up. So, those issues all touch healthcare. So it's a pretty broad range, but here are some of the ones I wanted to mention. I will start with, but not only talk about sustainability for the entire healthcare system. You've heard from various entities, you will hear from more. It's affecting all of us across the continuum of care in healthcare. It's affecting physician practices, our members. You'll hear, I think, from independent primary care, independent practice. 13 independent primary care practices have closed since 2017. Hospital-owned primary care practices are struggling. Inflation is increasing for all of us. The cost of healthcare to our own members, to insure their own staff, to hire their own staff, keep up with payments. As you've heard from others, unfortunately, federal Medicare payments have been reduced, especially in the area of professional services. Those fee schedules have been cut now for 5 years in a row. And in Vermont, there's an extra twist, which is, so the professional fee schedule, this is for the clinical services. So your doctors, your nurse practitioners, your PAs, they are paid on a professional fee schedule by Medicaid that matches Medicare's kind of funding formula. So when Medicare has a cut,
If there weren't changes that the legislature has asked for or that we've worked and negotiated with DIVA, typically the Medicaid fee schedule would also see a parallel cut. We have been working with DIVA for the past couple of months to try to look at ways to decouple that automatic linkage, and there should be a report coming to you soon. In fact, it might have been due today. Maybe you'll be seeing it today about methods for sort of decoupling that link. Not only do we think it's important to decouple from the cuts, but we think it's really important to adjust the fee schedules for inflation. So as the cost of providing medical care goes up, there is a linkage to a slight inflationary adjustment for professional services. We are following the AHEAD negotiations very closely. I'm sure your committee will hear a lot more about that. We expect a decision this afternoon, actually, by the Green Mountain Care Board on whether they want to pursue this new model of Medicare paying for healthcare services in Vermont. We've been really wearing our, again, sort of individual provider lens of how will that impact the delivery of care? How will that impact primary care, hospital care? So we are really waiting to see what happens this afternoon to know if this is moving ahead and we really need to start working on implementation issues, or if it's not moving ahead, what are the alternatives, especially because that is one of the few likely pathways to continuing funding from Medicare to the Blueprint for Health primary care program. So more to come. I'm sure we will be back talking about that. We support having what's called a primary care spend target, 8% of healthcare dollars, not increasing the overall pie, but what percent of that pie goes to primary care services. That's actually a requirement under the AHEAD model. So if AHEAD does happen, that will be kind of a built-in component we're looking at. If AHEAD does not happen, we have had bills addressing that separately, and I would expect we might be back with that.
Just so before you go forward.
Yeah.
Does the medical society have a stance or a hope for or against AHEAD?
We actually submitted comments on January 3rd, which is when the Green Mountain Care Board was asking they were looking for feedback. We had submitted earlier comments in the spring as well. I would summarize our position as cautiously optimistic, or the best option we have on the table currently. There are downsides, there are risks in terms of what we will still be losing from our current all-payer model, so one of the two areas of benefit, it comes with a primary care payment, a per Medicare beneficiary per month payment to primary care practice of about $17 per member per month. So that would be new federal funding that primary care practices in Vermont haven't gotten. It would be replacing some payments they've been getting under the ACO and Blueprint. So it's not kind of all new money, but it would be bigger than that. There also would be the continued Blueprint funding. And then if Vermont can stay kind of under our total cost of care estimate or negotiation with the federal government, we could potentially receive a reinvestment of a fair amount of federal dollars. So the AHS, the last number I heard from AHS, I don't know if it's changed, is about $138 million in the first year of the model, which is a lot of new federal dollars that would be called the East Fund, which could then be reinvested really in our continuum of healthcare services from primary care to mental health services, long-term care. There is I think, work to be done to determine who and how exactly that money would be divided up. But again, all positive possibilities that would all not exist without AHEAD. Some risks, that primary care payment only goes connected to your fee-for-service Medicare patients. So if you're a pediatrics practice, you have a lot of patients, younger patients in Medicare Advantage plans, you would not see any payments. Practices in our current ACO's sort of capitated primary care program called the Comprehensive Payment Reform Program. Not clear what a path forward for that program would be. So that would be a loss from our current program, but that's kind of that's going away regardless with the loss of the all-payer model. I think a lot to be determined of, and I'll let others, like maybe the Hospital Association, talk more about the global budget component. And I think a lot more risk. I think for primary care, there's sort of more clear upside. I think for the hospital global budget, a lot more unknown, and whether the math of that really works for our hospitals and healthcare system. That was maybe a longer answer
Thank
than you
you.
asked for, but that's
That's-
our view, that's our view of
Really
the AHEAD
helpful.
model.
That $17, I'm assuming, is on top of fee for service.
Correct.
Okay.
So fee for service, it's still for primary care, really a fee for service model with kind of an add-on payment.
Maury, did you have a question?
Yeah, I just want to be clear about the groups that you said that would not qualify for ahead payments. Would they still get the Medicare Advantage payments? They're not pulling everything.
They'd still get all their fee for service. They would just revert to fee for service, which would depend, the impact of that depends on what programs you currently participate with. So for example, all primary care practices will be losing their ACO population health payments because the ACO is going away. If you have patients then that can be connected to this ahead payment, you come out net ahead. If you don't have patients that can be linked to those payments, you come out net below where you would be at this, say compared to 2025. So there will be net losers.
There's nothing in ahead to replace the Medicaid payments from
So-
the ACO.
Correct, but the state could, right? So the ahead agreement is really only about Medicare's participation. So we have been talking with DIVA, with AHS about things like, well, okay, how, and CMS has been pretty adamant, as far as I know, that they are not going to move to a primary care capitated payment until, I think I have my date right, 2027 would be the soonest. So we have this 2026 kind of bridge year. So the question is, well, could AHS and DIVA find some way to kind of have a 1-year bridge kind of capitated primary care payment on the DIVA Medicaid side? So Medicaid really is expected to participate in ahead also. We don't know, I personally don't feel like I have all the details of what that looks like. Like they could match the 17 per member per month. That would be probably a pretty big Medicaid payment, but there's nothing to prevent DIVA, AHS from coming up with their own kind of state parallel program. The way they've been kind of thinking about it and talking to CMS about it is that the blueprint really is our state primary care program, payment program. So the state will continue all their payments under the blueprint, and that's, been their commitment to kind of a monthly practice payment.
I think it took us ahead on the ahead. Why don't we,
Move ahead from ahead. You can spend lots of time.
We'll have AHS in, to talk about more in depth ahead. Was it,
I'm not on ahead.
you're not, you're behind?
That was too easy.
Robert, did you
I
have a
just don't think
question?
there's much being done with it anyway.
Yeah.
I do have a question. Prior to Act 111, what percentage of time were primary care physicians spending on prior authorization work?
I have a slide on that.
You know what?
I have a slide on that. I'm getting to that.
Oh.
Do you want me to skip ahead or do you want me to come through with that? Okay, it's coming soon. All right, so look at that, the next slide, administrative burden. So this is, not necessarily, the good news is here, this is not asking for more funding for anything. This is about what can we simplify, streamline, take away from our extremely overburdened healthcare system that's keeping clinicians in behind a desk and not talking to their patients. So, we have a number of types of solutions, but things like, I don't see too many new faces this morning, but so most of you already did this work on Act 111, which was a big push, thanks to Chair Black last year to reduce prior authorizations. That is moving forward. Most of that bill goes into effect, actually went into effect 15 days ago, January 1st. There are some components you'll probably hear more about coming 2026. But one of the big reasons we worked on this bill was because of the amount of time spent on prior authorization. And Act 111 asked clinician organizations to do a survey of our members to look at what the impact was before Act 111 and after Act 111. And I actually just sent last night our first iteration of that. So this is kind of our baseline data of what did prior authorization look like. But since Act 111 was not in effect until January 1, in this fall, we asked how much time are you spending on prior authorizations? And if you look at the second bullet on this slide, and it includes the link to the full report, but completing 21.4 prior authorizations per week, spending 15 a little over 15 hours a week on prior authorizations. And that was a per clinician view. And then if you look in the full results, it includes, we also asked for data from administrators to give sort of a whole practice view. So they also had data around, taking all of their clinicians or all of their staff, how much time was it spending for their practice. So there's a lot of data in there, and I'd be happy to come back in more detail. Clinicians are reporting that it uses more healthcare resources. It actually adds to costs because if you're having to request additional office visits or sending a patient to an ED to get an imaging study done rather than being able to order it in your visit, delaying access to care, leading to serious adverse events and increasing burnout.
Jessica, did you send that email with those results to the whole committee?
I sent it, I was asked, I wasn't sure the process. The legislation said submit it to the chairs. So I submitted it to the chair and clerk, but I would be happy to send it to the full committee.
If you could send it to the full
Absolutely.
committee.
I would be very happy to do that.
I didn't look to see who it was sent to.
Yeah.
I'm sorry, I apologize. I should have forwarded it all to you.
I'm happy to do
So
that.
Jessica, just help me understand this thing. The percentage of time that a primary care physician, or the percentage of time that they were spending prior to Act 111. What was that?
The percent of their day that they would spend on this?
Authorization stuff.
Well, if they're saying that's about 2 hours a day.
Okay, now that.
So that's
doesn't
not-
do it for me though.
Okay.
What I'm looking at is, did the percentage of time that a physician spent on prior authorization get reduced?
Well, we don't know yet.
And how much?
We don't know yet because this was our survey. So Act 111 just went into effect 2 weeks ago.
Okay.
So all of this data is pre-Act 111. Then we have to repeat our survey next
Okay,
in a
so-
year or
Okay.
18 months and say, did it get better? So that's the goal. The goal is we have some baseline data and now can we look in another year and a half and say it's gotten better.
And what you're saying is the solution is to increase Act 111 to all primary care.
That is a piece. So the solution was Act 111, and now we have some tweaks to Act 111. One component of which is H31, which would expand. So Act 111 says primary care providers don't need to do prior authorization for certain, for imaging procedures, supplies, things like that. I will give my view and interpretation, which is the legislature intended it to apply to all primary care providers last year. There is a differences of opinion of a current interpretation, but the current guidance from DFR says it's only for primary care providers who participate in the Blueprint for Health.
Okay.
So H31 would expand it to all primary care providers.
And for the committee, we're doing a walkthrough of H31 on Friday.
Oh, thank you.
And we'll hear more about.
And then there will also be, we have some, I won't go into detail. I know I'm taking a lot of time, but some pieces, changes around telehealth, and not adding to our burden of privacy laws under this category for this session. Workforce issues, we know impact, again, the whole continuum of care, primary care, physicians, nursing, everyone. Specific to primary care, we redid our numbers of our current shortage this fall. And 2022 is unfortunately the latest licensing data we have, but comparing that to benchmark for need, we're short about 115 primary care physicians currently, and that's only looking like it will get worse. So there are some great programs in place already. We have a loan repayment program for primary care at the Larner College of Medicine that has a sunset. So we'd like to see that removed and making sure we're ensuring loan repayment funding. There's a really exciting new family medicine residency program that the federally qualified health centers are starting in kind of the central Vermont area and looking to help that program until it becomes self-sustaining. And then again, I won't go into detail, but just to let you know, our members also are really passionate about protecting patient access to care, preventive services, public health services. So we work on a range of issues in this area. We have some tweaks we're proposing to our SHIELD laws around protecting reproductive and gender affirming care services. We work on things like cannabis prevention, tobacco prevention, access to obesity and other medications, and preserving and strengthening mental health services. So lots of spectrum in our issues. And this is our team who's here with you regularly.
Leslie and then Mari.
So I'm looking at supporting public health and also what your policy priorities. So what's the process? Are you introducing bills or what's happening? I just want to understand.
Again, trying to be brief, it depends on the issue. On some of these, we do have bills we are either introducing or supporting. On some of these, it's responding to proposals from others and either supporting or in some cases opposing them. For every session, there's typically a bill that we consider weakening our public health protections in the regulated cannabis market, for example, like trying to expand advertising or increase the potency of products. So we follow those bills really closely and tend to be more reactive in that example than proposing something new. So it kind of depends on, but some of these for example, we are working to support and introduce some shield law changes.
Because that's what I was wondering.
Okay, yeah. Great. And I believe, I don't want to speak out of turn, that the Senate Health and Welfare Committee, several of those members are introducing a bill that has a number of components in that. So they may be starting with that issue, but I know they have a strong interest in it. And we've met with several of them about some components to strengthen our existing shield laws.
All right.
Do you know, is anyone reintroducing obesity medication legislation this year?
I believe, so I don't think we are this session. And the reason I say that is really the issue on obesity medication is the Medicaid program. So commercial insurers are covering them. Our state Medicaid program has not been, but we've been working, Jill Sudoff-Garin on our team has been working really closely with them and some of our members to get there without legislation. And there has been some progress, and I'm sure Jill can give you a more in-depth update. They are, I think, close to sort of having a policy. I think it's really been the balance of access with cost. So they've been, they've had several meetings and working on kind of what that might look like. So we're optimistic we may not need legislation in that.
Any other questions for Jessa? All right, thanks
Thank you so much.
And
Nice pictures, though.
Thank you.
Thank you, Jessica.
Next, I have on my agenda Jill Olson. Oh, there's. And I'm like, I have Jill, and I know what Jill looks like.
Hello, I just
Jill.
just couldn't get in. It was too crowded in the room.
You just couldn't what?
Let me just join the Zoom. What's that?
You just couldn't what?
Couldn't get in the room.
Oh, really?
It was packed.
Oh,
Felt like it would be.
so you were hanging outside, huh?
I was hanging right outside the door, hanging on Jess's every word. I was.
Party.
Thank you. Let's see if this works.
So go ahead. Actually, somebody reminded me of something yesterday. I think we should probably go around.
I'm about to make a mess with your audio. There we go. Sorry about that. I don't know why it wouldn't let me not turn audio.
I think we should probably go around the room just really quickly and introduce ourselves, not necessarily because the people in the room don't already know who we are, but there are people watching on YouTube. So really quickly, if you want to go around the room and introduce yourself, the committee.
What information do you want about?
Name and where you represent. How about that?
Leslie Goldman, Wyndham 3, Rockingham, Westminster, and Brookline, Bellas Falls area. Thank you.
All right.
Mari Cordes. I represent Bristol, Lincoln, Moncton, and Starksboro. And my other job, I'm a cardiology nurse at UVM Medical Center and a progressive care unit.
My name is Topper McFawn, and I represent Barrytown and part of Williamstown.
I am Alyssa Black, and I represent the northern part of Essex.
I'm Daisy Berbeco. I represent Winooski.
Heidi Critchlow, I represent Chester.
Guys, I'm really sorry. I can't get it to let me turn off the audio. It's forcing me to join. I apologize.
Sure, you already got to get in.
No,
Alan DeMar, I represent Enosburg and Montgomery.
Thank you. Madam Chair, I apologize. It usually allows you to decide to join audio or not, and it's just flipping right to joining audio.
And again, I can be.
Can you do that?
It's
Okay.
not just the muting, it's the the volume on your device.
Yes, well, every time I join, it turns it back up. But I can't get it to turn down to 0 is what's,
I
all
think we have your presentation posted.
right, let me try with,
So if so, is it?
you can mute me. But I think the problem is that the audio is coming through you can't make it not come through my iPad. So I don't know why it's doing that. Normally it just gives you the choice not to join audio. We all have it.
We all have it and it's posted on our committee
Okay,
website. So
and I have it.
anybody watching from home can follow along.
All right, I will monkey with this another time. I apologize. This is always tricky. So hello, Jill Olson. I'm the executive director of the VNAs of Vermont. So we represent Home Health and Hospice Agency. So it's nice to see those of you who I know and those of you who I don't know. And I wanted to introduce Eric Covey, who works with me. He's our director of communications, policy, and regulatory affairs. So he hasn't been in the building as much the last 2 sessions, but I think you're going to see more of him. So I wanted him to just be here and get all of you to have a chance to get to know him a little bit, at least by face, if nothing else. So thank you so much. So I think what I'm doing today is giving you an overview of the role of home health in the system and sort of what policy issues we are concerned about this year. Okay, good. You're nodding. Yes. Sure. Okay, you.
Exactly what.
Great. Okay.
You and what do you do?
Yeah. Okay, great. So, so first of all, just to talk a little bit, I'm on the first slide, the care at home across the continuum. Home health provides a variety of different services. And what I find often is that people know about one part of our services, but not others. And so I always just like to start with, what do we do? So the primary service home health and hospice agencies provide, there's really 2, is skilled home health. So that's medical care at home following, I don't know why the date is wrong in there. It's just, I was doing these last night. Just ignore that. I'm not having a good morning, obviously. So it feels like Monday, it's Wednesday. Hopefully I will improve as things progress. Yeah, do you see it? Okay, good. So that's medical care at home after hospitalization. My mom is getting home health as we speak, from a really nice team in Boston. And that it's a critical service. So that is medical care. We also provide long-term care. Often in this building, that's what we talk about the most because that's provided under a Medicaid program. And so it's often one of the pieces that needs funding. And that is really, it's not medical care. It's not provided by licensed people. It's care that helps people stay independent at home as long as possible. So people who would otherwise be eligible for nursing home care, actually getting care at home, help with bathing, feeding, dressing, those kinds of things. Hospice, we provide care at the end of life. Hospice is a service, not a place. So we can provide hospice in the home, in facilities, in nursing homes. There is one standalone inpatient hospice in Vermont, but for the most part, hospice is provided in the community. And then we have preventive services. There's maternal child health and various health screenings. And we used to do a lot of vaccination clinics. We do less of that now as the pharmacies have gotten more into that space. There's a lot less of that happening in home health. But we used to do a lot of flu clinics, that kind of thing. So that's sort of the big picture of the services we provide. And how I like to think about home health is that pretty much anybody who is getting care from a home health or hospice agency is someone who is not in a hospital and not in a nursing home. Otherwise, that's because that's pretty much the care we provide. Home health agencies are taking about 16% of hospital discharges right now. Long-term discharges to long-term care facilities, to SNFs, are about 17%, 17.4. So we take almost as many discharges as nursing homes do, as skilled nursing facilities do. And so when you think about it, there's already a crunch in the system for discharges, right? We're already struggling to get people discharged in a timely way from hospitals to the next level of care. If home health is not doing our piece of this puzzle, that problem gets that much worse. So we're not seeing too much of individuals who are appropriate for home health not being able to get a placement. There are some places in Vermont where that is happening. For the most part, we've been able to meet that need. But if that gets any less possible, it has a real impact on the whole system. Yes.
One moment, I think Woody has a question.
Yes. Home health, the work that you do for patients at home that can stay at home, how do you compare the cost of the service that you provide and what a patient would have to pay in a nursing home? I'm assuming there's a great difference.
There is a difference. Yep. So it's actually, there's two ways to think about it. So one is what the person is paying, and then the other is what the state is paying. So if the person is on Medicaid, then actually if they're at home, they're still paying for their house and for their food. So the person is actually paying more, because if they were in the nursing home, they would not be paying, Medicaid would be covering, including their room and board. For the state, at-home care is generally less expensive. Although it's actually, it's not easy math to do because there's other benefits people may be getting. But in general, yes, our understanding is that care at home is a less expensive option than care in the nursing home. Honestly, I think what matters the most today is that we don't have enough nursing home beds. And so if we're not doing that care, I don't know who is, because we don't have enough capacity across the long-term care system in any level of care.
And your service that you provide, it is a saving monetarily to the state.
Yes, absolutely.
And that care, can it go on indefinitely?
No.
Is there a period of time where you cut it off and perhaps that person has to go into a nursing home?
Yes. Long-term care at home is not 24/7 coverage. And so when people start to need constant supervision, if that's not something that their family is providing, yes, they often will need a higher level of care. This is part of why when we talk about the long-term care system, we're part of a coalition of long-term care providers. And what we say is that we need every part of the system, because many people will actually move through different levels of care in their lifetime. So we need it all to work, and we need it to all be available. But people who are receiving long-term care at home may be able to delay their time and shorten their time in a skilled nursing facility at the end of their lives, because they're able to stay at home longer because of the supports. But Choices for Care does not allow for 24/7 coverage at home. So people still have to be able to be safe enough in their homes when they're not getting support. But if they have trouble with groceries, if they have trouble with bathing, that's the kind of support that we can provide at home that might allow someone to be independent longer. That's what my mom's getting right now. She's getting PT at home from a home health, and she was getting help with showering. Now she's not. Now she's back to being independent. Yeah.
Thank you.
Just a few numbers. I looked up the last quarter of 24, just to give you a sense for how many people were being served in what setting. So there were just under 2,000 people getting long-term care in a nursing home. There were about 1,000 getting care from a home health agency in the home. And then there were about another 1,000 who were receiving probably care at home, which we call self-directed, meaning they're hiring their own caregiver. So about a quarter of those people were being cared for by a home health agency person.
Wendy, did you have a question?
Just a quick question. Self-directed care, that would be ERIS too?
Yeah,
Okay.
that is what ERIS is. Yeah.
Okay.
Yep. You know too much. Yeah.
What that is?
That's just the payroll provider. So it's people who are hiring their own caregivers, and the state gives them a payroll provider to make it possible for them to hire a worker, but it's using Medicaid dollars.
Yeah, so of course, I don't know what you mean by payroll provider, but we don't need to go there.
We really don't. No, I don't think it's relevant
Okay,
in this
good.
instance.
Huh?
Yeah.
I wanted to highlight one thing, because I know that, and I don't see it in your presentation, but I know that every once in a while it's an issue, and it's something I think it's important to understand. You are required to provide care.
That's right.
All agencies are nonprofits, correct?
Yes. Yes. Mm-hmm.
Okay, and you are tasked with providing home health throughout the state
Yes, yep,
and have no choice.
that's right. So,
By whom? That's federal or?
I'm gonna get there. You're right, it's not explicit in here, but I do have a plan. So,
Okay.
yeah.
Okay, great.
Yeah. Okay. So what I wanted to talk about a little bit is some of our pressures, and then that's where I'm going to talk about that issue. There are a lot of pressures on home health right now. We lost an agency last year. In March of 24, Franklin County Home Health closed its doors. We did not feel the reverberation of that in the way we might otherwise have because another agency was able to pick up that service area. So the VNA and Hospice of the Southwest region picked up that service area and is now providing care in Franklin County. So we didn't feel it, but I think it's really important to understand that we're a high Medicaid agency and now they're closed. They could not make the numbers work. And they tried for a long time, could not make the numbers work. So there are a lot of financial pressures and other kinds of pressures. There's the cost of travelers when we need to preserve access. So traveling nurses, temporary nurses, essentially. There are the workforce shortages that I'm sure you've heard about from anyone else who's testified about healthcare today. Rising wages, salaries, and benefits. So the cost of insurance actually hits us too. The patients are more complex than they've ever been in all levels of care. And then Medicaid reimbursement is consistently below costs. So we're at, we believe, about 67% of Medicare. So you've heard me, some of you in the past have heard me talk about how we're doing against LUPA rates, which is a lower fee schedule. We're at 100% of LUPA. We worked really hard to get there with your help. Thank you. But we spent the summer working with DVHA to figure out how do we compare to full Medicare, not just this lower fee schedule. And what we agreed was that we're at about 67% of Medicare in our Medicaid rates. So we try to, this body has tried to keep critical services at 100% of Medicare for things like primary care. We're well below full Medicare at this moment. And then our choices for care rates, that's our long-term care, are at least 30% below cost based on a rate study that we have. So we have Medicaid not paying the cost of care for sure. And then looking at the slide that says pressures, the payer mix, this is where I'm getting to that we take everyone by mission, but also by law. So both. In Vermont, we have a designated system. This is
that federal or state law?
State. This is unheard of anywhere else in the country. Nobody else does it this way. We have designated territories for home health agencies, and this is something we wanted. And the trade-off is that we serve everyone, regardless of ability to pay, regardless of what insurance they have. So if they're appropriate for the service, we have an obligation to provide services for them. We've had to work with AHS on dealing with some of our workforce shortages because we can't safely take care of people if we don't have the staff. But what that means is our Medicaid payer mix, how the proportion of our revenue coming from Medicaid is really high compared to other places. And this is why I'm going to say again, Franklin County closed because they had so much Medicaid, because it does not pay. So I got this interesting data from the auditor who audits most of my members and has home health agency accounts all across New England. And what they are seeing is that the most profitable agencies are the ones that have almost no Medicaid. In New England, the agencies take a little more Medicaid than the most profitable, but not that much. In Vermont, we're taking quite a bit more Medicaid. So we're taking in the statewide average is about 18%. Some agencies are as high as 30%. So we have this higher proportion of individuals that we're serving at below cost. And we only get paid by government payers. So there is no one else to make this up other than our communities with our fundraising. There's a limit to how far that can stretch. And unfortunately, Medicare is cutting us. So that's the next slide. The pressures, it says pressures Medicare. So it used to be, and our system is sort of built on this, that we had Medicare margins that allowed us to support this level of loss. And Medicare is cutting home health. They have been for more than a decade, but they're sort of on a current like theory about why they're cutting us. Part of why they cut us is because the only thing Medicare looks at when they think about how well they're paying home health is traditional Medicare. They don't care about Medicaid, and they don't care about Medicare Advantage. So Medicare Advantage is managed care for Medicare, and they are allowed to pay us whatever they want. And it's often terrible. Not always, it depends on the plan, but some plans are paying below Medicaid. So Medicaid is actually a better payer. So our best payer, Medicare, is slowly becoming our worst payer. So that's just not going to work. So on a federal level, what we really would like to see, and I do not think we're going to get this under the administration that is coming in now, would be for Medicare Advantage plans to have an obligation to pay home health at least Medicare rates. That does not exist in federal policy. It's not a thing. So we have to negotiate with big national companies. Little Addison County Home Health is negotiating with big national companies, and there's nothing our Vermont insurance regulators can do to help. They have no authority over Medicare Advantage plans. This is completely out of all of our control. So Medicare has cut our base rate. We're heading to 10%. We'll be at 10% by next year. So they think they're overpaying us. They put a new payment model in place in January of 2020. They think they've been overpaying home health ever since. And every year they cut the rate back more. Every year we fight. Every year they cut it a little less than they said they would. They're getting to the same place. They just took a little longer. And they have the authority to claw back every penny that they believe they overpaid us all the way back to January 1, 2020. So far, they haven't done it, but they have that authority, which is really, really scary when we see an administration coming in wanting to figure out how to spend less on things like Medicaid, right? So we've got this like open debt to the federal government that they have not chosen to exercise, but they could. Congress hasn't fixed this. We keep asking them to fix it. They haven't. So we have this risk of this large clawback of overpayments. So we're really concerned about the full financial picture, especially for agencies in Vermont that are taking all comers, regardless of ability to pay, if they're qualified. So I think we're going to see we're going to see those pressures continue to mount. I'm going to move to healthcare reform. I know I have no good news. I'm sorry. I have no good news this morning.
I'm just feeling this sort of tension of, we need more long-term, and that the right way to take care of our population, and at the federal level of clawing back on those programs. And I'm still, even that happened in the Biden administration. So now we're moving to the next one. I'm just feeling really confused about it. And I don't know if there's any path, is there a path for us? Perhaps not. Certainly not with Medicare Advantage. I get that. Is there anything going on in the head negotiation for long-term care?
Not for long-term. Yeah. Well, I'm going to get there.
Okay.
So this body already did the biggest thing that you could ever do for us, which was you got rid of our provider tax, which was like having an extra 4.5% Medicare cut every year. So we remain grateful. Our situation would be more grim without that change. So that was a big change that you made, and it made a big difference. Where I think we are now is that I think legislators need to understand that we cannot afford to provide any more services at below cost. And so we're going to have to start to make some really hard choices because there is no money to provide services at below cost and without spending down every dollar of reserves that agencies have. When agencies spend down all of their reserves, eventually they can't make payroll and then they close. That's the path. I think our message is really, we need to have our Medicaid rates at the Medicare level. And this is not really for this room, but for down the hall. If we're going to provide long-term care at home, it has to be paid for at cost. We can't do it below cost. We don't have any resources anymore to do services below cost. So that's not really in this committee. That's Human Services Committee. But for us, it's all, one piece, right? Where my members are single organizations that are trying to make their budgets work. In terms of healthcare reform, there's a trend that drives me crazy, and we've seen it over and over again. There's a we have a lot of reliance in our plans on home and community-based services, but we don't directly invest in them. So that's the trend. So Choices for Care, that's what Choices for Care is. The whole idea was let's get people out of facilities and into home and community-based services. That's the concept. And we did it. We're at about 50-50 facility, home. That was our goal. We met all of those program goals. And home health agencies are going to have to start exiting that program because they cannot afford to do it because we did not have regular investment in the home and community-based services. So when I think about healthcare reform, I always say it cannot look like Choices for Care. That did not work. But what we see are things like, so the Oliver Wyman report coming out of Act 167 has one of the big goals is to move care out of hospitals and into the community. That is a great idea. There is no roadmap in that document for how to get money directly to home health agencies. Savings in other parts of the system does not accrue to us without direct investment. There is no mechanism, there is no path. So I get very frustrated actually when I see, well, we're going to take these savings and somehow we're going to invest in other services. If you're not paying us a rate for the services we provide, you're not helping home health. It has to be dollars at the time that we're providing the service. That's the only way. It can't be later. It can't be a special program. None of that. And that's how we always do it. Like, let's sort of on the side, try to direct a little money over to the home-based services. Doesn't work. CMMI, that's the federal entity that envisioned ahead, no focus on home and community-based services at all. When you ask them, so when we went to the various meetings they had, and I would say, well, you want hospitals to basically not provide any care that they don't need to provide. How are you going to support home health and other community providers? And they would pretty much ignore my questions. So CMMI is not focused on the fact that they've got their partner at CMS cutting us. At the same time, they need us, CMMI's plans need us to do more. Now, this is an area where the administration of Vermont, so with the Scott administration or AHS, they understand this problem and they are trying to negotiate for dollars that would potentially be able to be directed to home and community-based services. I have no details yet on how that's actually going to work or whether that's going to be support for rates, I don't know what it's going to look like exactly, but they talk about that $138 million of, forget the acronym they're using, it's a new acronym. But that is to try to get at this problem. But I think that we don't yet have enough details for my members to know whether they think this is workable or not. But hospitals are never going to be able to push more care to the community or have more prevention in the community without all of those home and community-based providers. They just can't do it. They can't do it for us. And we can't do it for them without the resources. I think and then there's the other piece, which is there are other ways home health could actually be supportive of all of our healthcare reform goals, but it's not in our Medicare benefits. We're not allowed. There's a lot of people who would benefit from home health who are not allowed to provide care for. We don't get paid to provide care for them. So that's the kind of stuff that we need to work out. That's where some of the waivers come in. But whether there's a workforce to provide additional home health services is, I think, very much not clear. Wow, I'm just not very fun today.
No offense, but none of you have been particularly.
Has anybody been fun? I'm looking. No, okay. I don't expect anybody over here to be fun either. Okay, good.
Thanks, Jill.
Yeah, no, yeah.
Devin's gonna be fun.
Is she gonna be fun? Okay, Devin's gonna be fun.
None of it is unexpected.
No.
Yes. Thank you so much, Jill, for coming in.
Yes.
So we have Susan Ridson. She's on Zoom with us and we'll listen to, Susan is from Health First, and we're going to take a short break after Susan talks to us. So go ahead. Nice to see you.
Folks, I can tell a really silly joke. What's brown and sticky?
Maple syrup. What's
stick.
brown and sticky? What?
A stick. Really silly, I know. Sorry. All right, I'm trying to share my screen here. Hang on. Hi, everybody. I thank you for inviting us today. I'm sorry I'm not there in person. We do have Christina McLaughlin there in person, though. I don't quite see her, but
He's here.
can you guys see my presentation? You don't, do you?
Looks
No,
like
we
a
can
golf
see your
course.
really lovely screen saver though.
I wanna go
Not
there.
what I want. This happens, I have a Mac, so it doesn't always like work like I think it will. I apologize. All right, maybe you can see it now.
Yep,
PowerPoint?
yep, we can see that.
Excellent. Okay, great. So, hi, everybody. It's nice to be here. I appreciate the opportunity. My name is Susan Ridson, for those of you who don't know me. And I'm the executive director of Vermont Health First, and we're an independent practice association. So we represent physician-owned practices. And our mission is to promote and foster the long-term success of independent healthcare practices in Vermont. We think it's a really important model to preserve. So our network has 61 or 62 practices, both specialty care and primary care, located in 11 counties throughout Vermont. You can see them in the blue. And we have roughly 215 clinicians. We have 140 MDs, DOs, and about 75 advanced practice professionals. We actually have more clinicians in our network, but the way our membership model works, we don't count them all. But that gives you a good idea of our size. And of our 215 clinicians, 124 of them are primary care clinicians, taking care of roughly 88,000 patients. And then our 91 specialists offer a variety of services that I'll go into in a moment. And you can see our practices at our practice directory there. And we do estimate, although as Jessa mentioned earlier, it's sort of hard to get a handle on the total number of independent practices in the state. We estimate that we have anywhere from like around 90% of them are our members. And some of you might recognize, I tried to use pictures of our members in my slides here. In the lower left-hand corner is Richmond Family Medicine, right in the heart of Richmond. And then in the upper right-hand corner is Dr. Mike Fisker. He is the owner of Georgia Pediatrics. Now I can't see, okay. All right, so this slide just shows some of the specialties that we have in our network. This is not an inclusive list, but you'll see we have some pretty important specialists in our network: dermatology, ophthalmology, cardiology, gastroenterology, need fertility services. We have Northeastern Reproductive Medicine, Matri for obstetrics and gynecology, as well as Vermont Gynecology. If you need a carpal tunnel surgery, we have Lakeshore Hand Surgery. So these are just a number of our specialists, and oftentimes you can get their services for a whole lot less expensive than other options in the community. And many of the specialists do their procedures at the Green Mountain Surgery Center, which is an independent ambulatory surgery center that opened in 2019. Thanks in part to a few of our members, actually. And patients love the Green Mountain Surgery Center. And actually 2 years in a row now, they've been named in Newsweek's Best Surgery Centers in America. And this year they ranked 5th in the Northeast. So pretty nice option we have here in Vermont.
Susan, do you mind questions as we go along?
Oh, no, please go for it.
I think Woody has a question.
Yes, the hematology program in Northeast Kingdom.
Yes.
Is that the dialysis program?
No, it's Dr.
related?
Leslie Lockridge's office.
It's not related to the dialysis program in the Northeast Kingdom.
No, I don't think so.
Okay. Thank you.
All right, any other questions?
No, you're all set. Thanks.
Okay. So I just want to pause for a minute and talk about the value of independent practices. These are the very types of healthcare options our system needs more of. Time and again, they've been proven both on a national level as well as locally that independent practices provide very high quality care at a lower cost. Accessibility is usually quite good. The waiting times are generally shorter than other options in the community. And these are physician-led practices that they're part of the community. So they're really patient-centered, offering personalized and responsive type care. Because it's their name on the shingle outside. So they really are personally invested in providing the best experience possible. It's really important to have this model as part of our healthcare system. It allows for more options for care. I mean, some people do want to get their care in an FQHC or a hospital-owned practice, and that's great. They should have that option, but they should also be able to have the option to get their care at an independent practice if they want that, more intimate sort of experience. It also allows for more employment options for healthcare workers. Not everybody wants to work at a hospital system. So to be able to have these options is just more attractive for our healthcare workforce, and it just increases overall healthcare system resiliency. Like, for example, when there's a cyber attack or something, the whole system doesn't go down because it's not all one system. We are diversifying the options there. And then some of the top concerns and challenges. So this is where I start to get like everybody else. Hopefully my stupid joke will carry me a little bit here, but the top concern for independent practices are reimbursements. They just do not keep pace with expenses. And something to note about independent practices is their only source of revenue are the professional fees paid by Medicare, Medicaid, and commercial. And as Jessa talked about earlier, Medicare has been going down. Medicaid aligns with that, so that can go down as well. And then an independent practice, sort of like the Addison County Home Health Service, trying to negotiate with the national people, they just don't have the negotiating power to just get the reimbursements they need to keep pace with all the expenses that come in. The exorbitant cost of insuring their employees. We had a child care tax, which doesn't make or break any one practice. But when you have this trend of increasing costs, while reimbursements are either stagnant or declining, it's just a recipe for insolvency. And we have seen a number of practices close, in particular since the pandemic. So it's a huge issue. We're also really concerned about the fragility of primary care in general. They're not supported for the level of services and value they provide to the system. And just the entire system, our providers are struggling to get care for their patients because there's, access and affordability issues. And I know we all know we have a problem, and it is a concern for our practices. We also have this unlevel playing field. As I mentioned before, the only reimbursements for independent practices are the professional fees from the payers. There's no other opportunity we can't increase prices to offset the increased cost. And we don't have facility fees. We don't get, payments from the government like FQHCs do. There's no 340B stuff. I mean, it's basically it is those reimbursements. There's also other challenges. I mean, when we have these reimbursements that are lower than our competitors, we have a really hard time competing for workforce, which I know everybody is having a problem with that, but we're even more disadvantaged, I think, in that. And then there's also, this is a federal thing, but the Department of Education has a loan forgiveness program. And that program allows a clinician who comes out of medical school, whatever, has a lot of debt. They can work at like a rural health center or a nonprofit hospital or an FQHC and have their loan forgiven if they put in a certain number of years of service. Independent practices do not qualify as an eligible employer for that. So it's almost impossible to recruit a clinician who's got a lot of medical debt. They may even want to work at the independent practice. They prefer that, but they just can't do it because, you know, they can get their loan forgiven if they work elsewhere. So we lose people all the time for that, or we just can't get them. It's a real barrier. And then Jessa talked about this as well. It's just the excessive administrative burden on practices. Although I know this committee knows that well, has been very supportive in helping us address that. Thank you so much for those efforts. You know, as Medicare Advantage becomes a bigger part of the payer mix, you know, this is an ongoing, continuing, and growing problem that won't go away anytime soon. Then how you can help. You know, I think first and foremost is as you're reviewing policies and bills and so forth, ask yourself, how will this affect independent practices? Oftentimes the effect is either more severe on us or just affects us differently. And if you don't know, please reach out to Christina or I and talk to us about it. We're happy to chat more at any time. And then support efforts for sustainable and fair reimbursement. Jessa talked about this as well, but, you know, a perfect example is, you know, Medicaid aligns with Medicare. So when Medicare keeps decreasing their rates, you know, it can do the same for Medicaid, and there's no inflationary increase. So you can support, you know, inflationary adjustments for some of these fee schedules. That would help. There's also, you know, a fair reimbursement issue on the terms of independence. You know, many people don't realize, especially for specialists and for professional fees only, not even considering facility fees, independent, say, cardiologists will be paid far, you know, a lot less than a hospital employed physician for providing the exact same service. And it's just really just not fair. And it's also affects patients, because suppose you have a heart attack and, you know, we have independent cardiologists who do call at the hospital. And depending on who's on call that night will depend on how much the patient pays for that professional cardiologist service, and which just doesn't seem right. But we have that situation here. So I think we need some more fairness in how the physician professional fees are paid. Then some of you, or hopefully all of you, know that we been working with Mari on a certificate of need reform bill. For those who aren't aware, it's basically a permission slip to open up, say, an ambulatory surgery center like the Green Mountain Surgery Center or an independent imaging center, to be able to do that. And Vermont has one of the most onerous processes in the nation for this. So we're seeking to increase the threshold significantly for this. It's really a barrier in particular to like independent practices or clinicians, because you need deep pockets to go through this, you know, process. And there's, you know, plenty of research on certificate of need showing that it really worsens access and affordability issues, the very things we're struggling with here in Vermont. Happy to talk more to anybody about that, and encourage you to sponsor that bill. Like Jessa mentioned, we're also worried about the transition to a new payment model, wherever that may be. We also have submitted comments about AHEAD. So we have our thoughts on that. We do believe that you know, primary care needs some more support and needs to be held harmless in this transition. And then you can back policies promoting loan repayment, loan forgiveness options. You know, I know there's some stuff out there right now with AHEC and so forth, and those have helped independents. We still have that, you know, loan forgiveness Department of Education on level playing field there. I'm not exactly sure how to fix that one just yet, but it is something that we'd love to find a solution to. And then just in general, advocating for a level playing field for independent practices and recognizing the high value they provide to our system. Then just here's our contact information. I'm happy to talk to any of you at any time. So please get in touch.
All right.
Any questions?
Any questions for Susan? All Right, well, thank you for joining us today. And I think we're gonna take a break right now.
Thank you for having me.
Thank you for bringing a joke to us. Wonderful. That was. I think we're gonna take a break, 15 minutes. All right, so we'll be back at